Hello, everyone, and welcome to our module on the vestibular system. So if you look at this drawing on the screen, it shows the structures found in the ear. And in the video on the auditory system, I talk about the differences between the outer ear, the middle ear, and the inner ear. But within the inner ear, you can find the cochlea, which is the organ that's important for hearing sounds in the world around us. But next to the cochlea, there's this little chamber, and a vestibule is a name for a chamber. And within that chamber, you find these structures that I'm circling here with my pen. So years ago, when anatomists discovered this region of the inner ear, they called it the vestibule, and they called this apparatus that was inside of it the vestibular system. So the vestibule is the central portion of the inner ear. It's found within the temporal bone. If you look at this drawing on the screen, this is the vestibule that I'm circling with my pen right here. And the system found within the vestibule, called the vestibular system, is important for balance, posture, and also equilibrium. It's also very important for coordinating head and eye movements. When you turn your head to the left, you want your eyes to move with your head. Well, that turning of the head has to be sensed, and it's sensed by the vestibular system, and it helps to keep your eyes focused on the objects that you want to focus on. So you can think of the vestibular system as having two functional components, and the first one are the semicircular canals. There are three of these. If you look at this drawing on the screen here, I'm marking the three semicircular canals with my pen. They're these big loops. They have a bulge at the base called an ampulla. And the job of the semicircular canals is to respond to rotation of the head in the X, Y, and Z planes of motion. So basically, these three semicircular canals are filled with a fluid called endolymph. And within the endolymph, at the ampulla, there are hair cells that bend with rotation. And so when you rotate your head in one of the XYZ planes of motion, these hair cells sense that rotation and they release neurotransmitters, and that creates an action potential. And this sends signals to other parts of the brain. The semicircular canals will send more or less signals based on the degree of motion in the different planes of the axis. The other functional part of the vestibular system are the utricle and saccule. These are called the otolith organs. So once again, let's look at my drawing on the screen here. This is the utricle right here that I'm circling, and this is the saccula right here that I'm circling. There are these two circular structures found near the bases of the semicircular canals. And the job of these two organs is to respond to linear motion. So, for example, gravity pulling you down or moving forward or backward. The utricle and saccule, if you look down inside them, look like what's shown here on this slide. So they have these little hair cells surrounded by fluid and little stones. The stones are called otoliths. That's a Greek word that means ear stones. They're made up of calcium carbonate, and they sit near the top of these hair cells, like you can see in this drawing right here. And so when there's linear motion, these stones will drag the hair cells in response to that motion. And this is going to generate vestibular neural activity that lets the brain know motion that's occurring in a linear manner, meaning up or down or forward or backward. Once those elements of the vestibular system generate neural activity, it is transmitted via the vestibulocochlear nerve. This is one of the cranial nerves that I talk about in another video. It's two nerves in one sheath. The vestibular nerve is the one that innervates the vestibular system. The cochlear nerve innervates the cochlea of our hearing system. The vestibular nerve then sends signals to the brainstem, where you can find the vestibular nuclei. It also sends signals to the cerebellum, which I talk about in another video. This part of the brain is important for balance, just like the vestibular system is. And so eventually the signals from the vestibular system will reach the vestibular nuclei in the brainstem. They're found below the fourth ventricle in the pons and the medulla. And they receive this input from the vestibular nerve, and then they have many, many outputs. It's low yield to know about all of them, but it sends signals to lots of different places, like the cerebellum for balance, the thalamus for sensory information, other cranial nerves that control eye movement, and that's because the vestibular system helps keep your eyes focused, like we talked about before. Okay, so all that's the basic anatomy of the vestibular system, but what's really important to understand is what happens when there's dysfunction of the vestibular system due to some type of pathology. So let's talk about that now. So the major symptom of vestibular dysfunction is vertigo. This is a sense that the room is spinning even though the head is still. So basically, the brain is sensing motion, but there is no motion of the head. And this is different from being dizzy or lightheaded, where patients feel faint, like they might pass out. This is a definite sensation of the room spinning around you. And so in clinical practice, when you meet patients and they say, I'm dizzy, one of the first things you need to do is figure out, are they lightheaded, feeling like they might faint, or do they have vertigo and a sensation of the room spinning around them? Now, the vertigo often makes people nauseous, and that can also make people vomit. And then the other symptom of vestibular dysfunction that you have to be familiar with is nystagmus. This is a rhythmic oscillation of the eyes. So let's talk about this now in a little bit more detail. So nystagmus is an enormously complicated subject, but an easy way to think about it as a med student is that in order for your eye to stay midline and fixed, you need cranial nerve 8 on the right and cranial nerve 8 on the left to both be working normally. If one of these cranial nerves on one side becomes dysfunctional, what's going to happen is the other side is going to dominate and the eye is going to drift slowly in this direction. Then the brain's going to sense that the eye is drifting away from midline and it's going to rapidly yank it back. And that's what happens in nystagmus. You see a slow oscillation of the eye towards one side and then a rapid correction back towards the other side. So nystagmus is really just a manifestation of disruption of the vestibulo-ocular reflex. This reflex focuses the eyes at the midline when the body moves. And when there's dysfunction of the vestibular system in the inner ear, that disrupts this reflex. And what happens is the eyes move slowly in one direction, and then there's a fast correction back in the opposite direction. And so the most common type of nystagmus is jerk nystagmus. And this is what happens when the eyes drift slowly in one direction, and then they rapidly correct or jerk back in the other direction. And jerk nystagmus is named for the rapid correction, the fast direction that the eye moves backward after a slow drift in one direction. So for example, you can have left jerk nystagmus or right jerk nystagmus. You can also have torsional and rotational nystagmus. This is when the eye is trying to rotate in one direction and then corrects back in the other direction. And then you can also have upbeat or downbeat jerk nystagmus. There are many other types of nystagmus. One type that you should at least have heard of is called pendular nystagmus. This is a very rare type of nystagmus where there's no fast or slow direction. Basically, the eye moves with equal speed in each direction. This is very rare. It sometimes occurs in children with certain congenital defects of the central nervous system. You can also see it in multiple sclerosis and some types of brainstem strokes. The type of nystagmus that the patient displays tells us something about the underlying cause of their vestibular dysfunction. So let's talk about that now. So peripheral vestibular dysfunction refers to problems with the vestibular system in the inner ear. And when patients have this type of problem, they develop left-right, which is horizontal nystagmus, or torsional rotational nystagmus. On the other hand, central vestibular dysfunction is what happens when patients have brainstem strokes, for example, or tumors compressing the brainstem. And when this type of vestibular dysfunction occurs, that leads to upbeat, downbeat, or vertical nystagmus. And this information right here is very high yield to know. It often comes up in board questions. They describe the nystagmus, and they want you to know if that indicates a peripheral or central problem. So basically, nystagmus and also vertigo in general are differentiated into central causes and peripheral causes. A peripheral cause of vertigo or nystagmus is a cause outside the brainstem. So this is usually some type of inner ear problem. Some examples of this are BPPV, which we'll talk about shortly. That's where those otoliths are misaligned. Vestibular neuritis, which is inflammation of the vestibular nerve. And also Meniere's disease, where there's a problem with endolymph in the vestibular system. In contrast, central vertigo or central nystagmus is evidence of central nervous system dysfunction. This means there's a problem in the brainstem or the cerebellum. This could be a stroke or a TIA in the vertebrobasilar system. It could be a stroke or hemorrhage into the cerebellum, or it could be a tumor in the posterior fossa compressing on the brainstem. In general, peripheral causes of vertigo are usually benign and not life-threatening, whereas central causes can be life-threatening. And so clinically, when you're evaluating a patient with vertigo, you want to try and establish whether that patient has peripheral or central vertigo, because this is going to help you know what type of workup you need to do. So what are some of the clinical features you can see in patients who have central causes of vertigo? Well, first of all, a classic finding in central vertigo is nystagmus that is purely vertical. So it's either all upward or all downward. There's no left-right nystagmus. There's no torsional nystagmus. Another feature of central vertigo is nystagmus that changes direction with the patient's gaze. So for example, they have left jerk nystagmus when they look to the left or gaze to the left, but then the nystagmus becomes right jerk nystagmus on rightward gaze. Another finding of central vertigo is immediate nystagmus when you change the head position on the patient. We'll talk more about this later, but there's a diagnostic test used in benign positional vertigo where you ask the patient to lie flat and turn their head to the left. In patients who have central causes of vertigo, that change of position will immediately lead to nystagmus, instead of there being a delay of a few seconds before nystagmus begins. Another clinical feature you can see in central vertigo is diplopia or blurry vision. Remember that the vestibulo-ocular reflex keeps the eyes aligned, so if they become misaligned, the patient will complain of blurry vision or diplopia. The type of diplopia that occurs with central vertigo is called binocular diplopia. This means it's only present when both eyes are open, because the problem is misalignment of the two eyes, so they have to both be open for that to be appreciated by the brain. If you cover one eye, there's no more misalignment and the diplopia goes away. Another finding you can get in central vertigo is skew deviation. This is vertical misalignment of the eyes, so one eye may be higher than the other. Also in central vertigo, you often see dysmetria. This refers to abnormal finger to nose testing. So in the finger to nose test, you ask the patient to touch their nose, then touch your finger, which you hold in front of their face, and go back and forth. If they can't do that, that's called dysmetria, and that's a feature of central vertigo. And then beyond this, because central vertigo is often caused by brainstem problems and strokes and things like that, you often see other central nervous system symptoms, things like motor weakness, sensory loss, and so forth. In contrast, peripheral causes of vertigo have clinical features like what I've summarized on this slide here. So first of all, these patients tend to have mixed horizontal or torsional nystagmus. So the nystagmus could be left-right, it could be torsional, it could be a mixture of these things, but it won't be purely vertical like what we talked about in the last slide. Also in peripheral vertigo, when you do positional testing, which we'll talk about shortly, there is a delay from when you change the patient's head position until nystagmus develops. Another feature of peripheral vertigo is that nystagmus may fatigue with time. So if you change the position of the patient's head, there may be a delay and then nystagmus will occur, but as time goes on, the nystagmus will go away. In contrast, it often persists in central causes of vertigo. And then in peripheral causes of vertigo, there are usually no other central nervous system symptoms, things that might suggest a brainstem problem. And other testing will be intact, so proprioception, Romberg test, all these things will be normal, because really the problem is just with the peripheral vestibular system, not the brainstem and deeper central nervous system structures. Okay, so that's a hugely important topic that you need to understand as a medical student, how to distinguish central from peripheral causes of vertigo. Now what I'm going to do for the remainder of this video is go through a couple of common causes of peripheral vertigo. And we'll start by talking about benign paroxysmal positional vertigo, or BPPV. This is vertigo that occurs with head turning or position changes. That's why it's called positional vertigo. And it's caused by calcium debris in the semicircular canals. This is referred to as canalithiasis. So if you look at this drawing on the screen here, if you get some calcium debris in the semicircular canals, what's going to happen is when the patient turns their head, they're going to get abnormal signals sent to the brainstem, and that's going to lead to vertigo. This is diagnosed through a bedside technique called the Dix-Hallpike maneuver, which we'll talk about in just a second. And importantly, if you perform the Dix-Hallpike maneuver and you don't get the typical result, then you need to consider imaging, because BPPV is so common that you often diagnose it with the Dix-Hallpike maneuver. But if you do that and you get some strange result that doesn't fit, then you have to have a heads up that that's a red flag that the patient could have a central cause of vertigo, and they may need imaging in order to look at the brainstem and rule out things like strokes and tumors. Okay, so let's talk about the Dix-Hallpike maneuver. So this is a diagnostic test for BPPV, and the goal of this test is to reproduce vertigo and nystagmus in the patient. So you start with the patient seated, just like what's shown here in the top panel. You assist the patient in extending their neck and turning it to the side, and then you rapidly lie the patient down on the table and you let their head hang over the end of the table. And that's what's shown here in the bottom panel. The examiner has helped the patient to lie down and their head is now hanging off the edge of the table, turned slightly to one side. If the patient has BPPV, they should have a typical result, and that is the following. First of all, there will be a delay in the onset of symptoms for about 5 to 10 seconds. We mentioned this earlier. At that point, vertigo will develop, and the patient will develop torsional nystagmus. And then when you sit the patient up, the symptoms will go away. And if you repeat that maneuver, they will have fewer symptoms each time you repeat the maneuver. Make sure you know this. This is the expected result for BPPV. And as I mentioned earlier, if you get findings that differ from this expected result, then you have to consider that a red flag that the person could have central vertigo, and that's often when imaging is done. And then the treatment for BPPV is the Epley maneuver. Basically, this is a physical maneuver you tell the patient to perform to reposition the displaced otoliths in the semicircular canals. Basically, what you advise the patient to do is begin in a sitting position and then lie back quickly into the Dix-Hallpike position that we talked about in the last slide. They stay in that position until the vertigo subsides, then they rotate their head, wait a few seconds, roll on to the other side, wait again, and then they slowly sit up. And usually most physician offices have a detailed printout of exactly how to do this with lots of pictures, and you hand it to the patient. And if they do this a couple of times a day, usually the BPPV will resolve on its own. And the reason it resolves is because you're repositioning those displaced stones in the inner ear. Another cause of peripheral vertigo that you should be familiar with is vestibular neuronitis, also known as labyrinthitis. This refers to a neuropathy of the vestibular portion of cranial nerve 8, the vestibular nerve. When this happens, the patient will develop clinical features of peripheral vertigo, like we talked about before. This is usually a benign, self-limited condition that requires no special treatment. It's often post-viral, so a patient who had an upper respiratory infection, the URI will resolve, but afterwards they will have some vertigo from vestibular neuronitis. And then the final disorder we'll discuss in this video is Meniere's disease. This is a cause of peripheral vertigo due to endolymph fluid accumulation, also known as hydrops. So if you look at these images on the screen, they pretty nicely show the pathophysiology of Meniere's disease. So there's always some fluid found in the cochlea and the vestibular system and the semicircular canals, just like you see over here in this image on the left. But in Meniere's disease, there's excessive fluid accumulation. That's called endolymph fluid accumulation, or hydrops of the inner ear. And that's going to lead to problems with the vestibular system and also problems in the cochlea with hearing. Basically, it's swelling of the entire labyrinthine system, meaning the system of the inner ear. So the clinical features of Meniere's disease are a triad of symptoms. The first one is tinnitus, which is ringing in the ear. The second one is hearing loss, and the type of hearing loss that occurs is sensory neural. I talk about what sensory neural hearing loss is in detail in the video on the auditory system, but by way of reminder, it's a type of hearing loss related to the cochlea, and the Weber test will be louder in the normal ear, and the Rene test will show air conduction greater than bone conduction in the ear that has decreased hearing. And once again, I go over all these things in detail in the auditory system video. And then the final element of the triad is vertigo from dysfunction of the vestibular system. Shown on this slide are some of the treatments for Meniere's disease. So first of all, if patients avoid high salt foods, this will often help a lot. It will decrease the swelling in the semicircular canals and the cochlea. Same thing will happen if patients avoid caffeine and nicotine. These are vasoconstrictors. They decrease the flow of fluid out of the inner ear. And so by avoiding these types of things, patients often feel better. So many patients can be treated with so-called lifestyle modifications and not drugs. But then in some cases, drugs are used. The type of drugs that are often used are diuretics. And the idea is just to reduce the amount of fluid in the body and hopefully also reduce the amount of fluid found in the vestibular system and the cochlea. And that concludes our module on the vestibular system.